So, Bismillah ar-Rahman ar-Rahim. I will start by thanking the organizers, أستاذنا وحبيبنا دكتور أحمد العسكر القائمين على SSBMT, Dr. Ahmed Al-Ibsi for the invitation. I was given this talk, Mantle Cell Lymphoma, where we stand in 2024, as if it's not difficult enough to speak about Mantle Cell Lymphoma because there are too many unanswered questions. And 2024 has just started. But inshallah, together we'll do the best out of this. These are my disclosures. So this is what I'm going to speak about, risk categories, optimizing of chemoimmunotherapy, novel agents and future direction. And I will have too many clinical studies running where we are awaiting some answers to be, some questions to be answered. So, likewise, diffuse large B-cell lymphoma, mantle cell lymphoma is not one disease. It's a heterogeneous disease. Mainly, we are distinguishing between the classical mantle cell lymphoma, which is an aggressive disease. It's usually SOX11 positive, unmutated IgG/HV. It has an aggressive behavior, and around 10% of the patient they are having TP53. And the other one, which is the other form, the indolent form, is it could be a leukemic one, non-nodal, or involving just the gastrointestinal tract, or nodal indolent mantle cell lymphoma. These group of patients have usually favorable prognosis, less aggressive disease. They are characteristics by a Ki67 if less than 10%, and usually they do not express SOX11, and they are IgG/HV mutated. So mantle cell lymphoma is a disease where it favors males than women. Yani, all women be happy. Your chance to get mantle cell lymphoma is less than females. The median age is 60 to 70 years old, and the majority of the patients when come to us, they are in advanced stages. 20 to 60 to 30% of the patient, they are having a leukemic presentation and having a favorable prognosis. Extranodal involvement is common in this kind of disease. The prognostication of mantle cell lymphoma, as we mentioned, we have a low-risk patients. Ki67 is less than 10%, SOX11 negative, IgG/HV hypermutated or mutated. They don't have complex karyotype. GI tract only disease is usually having a favorable prognosis. The high-risk patient, as we mentioned, blastoid and pleomorphic histology, the Ki67 is 30% and above, and they have a complex karyotype and TP53 mutated usually. The risk categorization of the patients is important because the overall surveillance, as the prognosis of the patient is different. You can see here MIPI, which is age, ECOG, LDH, and WBC. They have the low-risk patient, they have a better overall survival than the high-risk patients, as high MIPI score patients. Ki67 30, and above this the cutoff is 30, more than 30, less favorable prognosis, less than 30, prognosis better, but TP53, they don't have a good prognosis. The blastoid variant versus not blastoid variant, also favorable versus not favorable. So when we decide on treatment, it's not only the disease factors what we are looking for, and patients factors, age, comorbidity, and so on. So, and we have learned in the last few decades to distinguish patient, and this is very important when we start the patient on initial treatment, to distinguish between patients who are eligible for intensive chemo and those who are not eligible for intensive chemo. This is very important at the beginning of treatment. But we have always to, when we look to the patients, we have always to consider one factor, which is, shall I treat this patient or shall I observe this patient? Early treatment is not necessarily improving the outcome of the patients. The advanced stage patient, as I'm speaking of stage 3 and 4, stage 1 I would treat, maybe radiation, but I'm speaking here about advanced stages. If you treat a patient early or late, or later on, the same outcome. That's why some a subset of patients, they might be observed and you don't need to treat them. The advancement of management of Hodgkin mantle cell lymphoma has started 2002 with the introduction of R-CHOP. R-CHOP at that time, it was a magic for all B-cell lymphoma, including mantle cell lymphoma. And advancement continues with the introduction of high-dose RSC and autologous stem cell transplantation. And there are different trials. Here are some selected trials done in patients who are eligible for transplantation, and this is a landmark trial. The MCL Younger trial, where young patients were treated with either 6 cycles of R-CHOP versus 6 cycles of R-CHOP alternating with DHAP. DHAP, there is cytarabine, right? The patient thereafter, without randomization, the randomization happened at the beginning, and the patient thereafter, both groups went, if they reach complete remission or a partial remission, for autologous stem cell transplantation. And you can see in the right side that there was an improvement of the TTF, time to treatment failure, in favor of patients who receive cytarabine containing regimens. And we have been always saying in the last year, yes, cytarabine containing regimen is important. Cytarabine containing regimen is important if you go for autologous stem cell transplantation in patients who are eligible for that. But so far, there is no improvement in overall survival. That's what we have to keep in mind. So a subset of patients from the MCL2 and MCL3 trials looked whether the autologous stem cell transplantation improves substantially the outcome of patients with difficult to treat mutation, difficult to treat disease, which is the P53. It doesn't influence too much. The patients with P53 still, they have, without the era of autologous stem cell transplantation, they had also a not very good outcome. Then we want to improve the outcome of autologous stem cell transplantation further. So this trial looked, the LISA study looked to maintenance rituximab post-autologous stem cell transplantation, also for patients who are eligible for intensive chemo, versus observation. 3 years of maintenance rituximab versus no rituximab. There was a progression-free survival improvement and overall survival improvement, and these data were really striking, and even the follow-up data just recently published, beyond 10 years and beyond, you can see that the progression-free survival is increasing from around 20% now to 30%, and the overall survival benefit is also increasing from roughly 9% to now 11%, which means rituximab maintenance is really something which we have always to think on when patient is getting his autologous stem cell transplantation. But this study did not answer the question whether bendamustine, rituximab, prior autologous stem cell transplantation is as good as cytarabine containing regimen. And this was addressed here in the randomized trial, the SWOG trial S1106, And you can see here that the progression-free survival and overall survival, if patient was receiving BR prior autologous stem cell transplantation, it was not bad. It's not as good as hyper-CVAD and cytarabine, but the study was terminated because of the toxicity of hyper-CVAD. And another question, another answer, what we getting for the answering this question is from the retrospective data collection from British Columbia, where they collected their data for patients who received RB, rituximab, bendamustine, followed by autologous stem cell transplantation, followed by maintenance rituximab, and compare these data, cross-comparison, retrospective and randomized trial, and they didn't find any difference in terms of progression-free survival and overall survival if patients receive bendamustine and rituximab. So why to go now for cytarabine? Why to go for cytarabine-containing regimen? Because it's toxic. So moving forward to patients who are not eligible for autologous stem cell transplantation, and we have a couple of trials. The first two trials are the STEEL trial from Germany, from Rommel, then the BRIGHT trials, and both of them conducted in follicular lymphoma and mantle cell lymphoma. They showed clearly that bendamustine rituximab is superior to R-CHOP, and since that time we have been using for elderly patients bendamustine and rituximab. But these two trials did not answer two important questions. The first one is whether in elderly patient, bendamustine and rituximab is as good as low dose of cytarabine containing regimens. And this is being answered maybe in the data collection from the Flatron records with more than 4,000 patients. And you can see here in the upper part of this cartoon that patients who received bendamustine and rituximab, they did as well as patients who received cytarabine-containing regimens. Another important question, which was not tackled and answered in the BRIGHT and the STEEL trial, can I use rituximab maintenance? Is it beneficial after bendamustine? And this was also addressed in this retrospective data collection, where the red curve is the bendamustine rituximab followed by maintenance rituximab. You can see here that this group of patients are doing the best in terms of progression-free survival or time to next treatment, and the overall survival was not different. So science is moving forward. Now we have a new era of PTK in the management of CLL and mantle cell lymphoma. And these agents are being now incorporated in area line. And we have plenty of studies where we got some trials results, and others are still running. In treatment-naive transplant-ineligible patients with chemotherapy as backbone, as a novel agent with chemotherapy, or treatment-naive transplant-ineligible patients with chemotherapy as backbone, or even without any chemotherapy. So we'll see it together in the next slides. Triangle, recently published, and I think all of you are aware about this, R-CHOP, R-DHAB, followed by autologous stem cell transplantation. That's what we have been doing it for a couple of years, versus R-CHOP, R-DHAB, plus ibrutinib, and ibrutinib here was given only in those patients who received, during the cycles where the patient received R-CHOP. As when they received R-DHAB, the 3 cycles, they didn't receive ibrutinib. Followed by autologous stem cell transplantation, followed by 2 years of ibrutinib maintenance, versus the same regimen as an IE, but without transplantation. So the event-free survival, you can see that the ibrutinib arms, they are better, by far better, in terms of failure-free survival than patients who receive autologous stem cell transplantation without ibrutinib. Overall survival is still, I think, premature, and we have to wait a little bit in order to make a final decision. ibrutinib with R-CHOP and R-DHAB, it does well in all high-risk subgroups, with the exception of MIBI. It was good in all MIBI scores. Then, and this is a very important trial is currently running. It will answer a very important question, whether do we still need cytarabine-based or cytarabine regimens to be integrated in the management of patients with elderly patients. And in this trial, BR and rituximab cytarabine will be compared with BR and rituximab cytarabine and acalabrutinib. We know acalabrutinib might induce less arterial fibrillation and so on than ibrutinib, versus pure PR and acalabrutinib. This is a very important trial, and we are waiting for the results of this trial. This study will also address the MRD negativity rate, and the MRD negativity, or MRD, is being discovered now in diffuse large B-cell lymphoma and follicular lymphoma, and we have it also in CLL and mantle cell lymphoma. And this is another very important trial in transplant eligible patients, acalabrutinib and CHOP without vincristine, but here bortezomib is being replacing vincristine, alternating with acalabrutinib, rituximab, and cytarabine. Cytarabine is still here incorporated. Another study, which is the BRIDGE trial, is looking to R-CHOP alternating with R-DHOX. Platinum was removed and replaced by, cisplatin was removed and replaced by oxaliplatin, together with zanubrutinib. Autologous stem cell transplantation was optional, still optional, and patient receive zanubrutinib. Then, in patients who are not eligible for autologous stem cell transplantation, the SHINE trial, which is a phase 3 trial, randomized ibrutinib plus bendamustine and rituximab versus bendamustine and rituximab in patients who are not eligible for transplant. And you can see ibrutinib improved the progression-free survival. Arterial fibrillation rate increases with ibrutinib up to 14%. Although the endpoint of the study was met, but unfortunately the study did not lead to first-line approval of ibrutinib because of the toxicity, as you can see here, and there was no overall survival benefit. And this is really a good one. This hopefully will lead to approval of acalabrutinib. We don't know in patients who are ineligible for autologous stem cell transplantation. This is the ECHO trial, as of bendamustine rituximab plus acalabrutinib or placebo, and we are awaiting the results of this trial. Hopefully we will have less side effects because acalabrutinib has, in terms of cardiac events, less events than ibrutinib. And this ECOG E1411 trial is looking whether we can enhance the efficacy of BR by adding Velcade, which is bortezomib, in the induction treatment, and another 2 arms in this 4-arm randomized trial is addressing whether we can add lenalidomide to the maintenance. And you can see here Velcade did not improve the outcome of the patient, also the overall response rate and the complete remission rate is exciting in both arms. Regarding the maintenance, it's too early to decide and to say whether the adding of rituximab and lenalidomide post this regimen will improve the outcome of the patient. And this is also another very important trial currently running, is an MRD driven. And this might help us in saving money and saving toxicity for the patient. Patients who are MRD negative after induction regimen, if they are MRD negative and reach complete remission in the images, they will be randomized. They will be randomized to receive rituximab maintenance or autologous stem cell transplantation and rituximab. This will really address the question whether those who are MRD negative, they don't need autologous stem cell transplantation. And we have the novel agent now are introduced slowly in the upfront setting in different groups of patients with mantle cell lymphoma. This is the Boven trial, where this is dedicated for TP53 mutated patients or those with P53 overexpression. Zanubrutinib will be here used together with obinutuzumab and venetoclax as a pure chemotherapy-free regimens. We have some data really of striking overall response rate of 95% and the 16 months progression-free survival in this really very difficult to treat population is very encouraging with 75%. Acalabrutinib, lenalidomide, and rituximab. You can see here the overall response rate, and with this pure chemotherapy-free regimen is really very high. Overall response rate is 100%, complete remission rate is 83%, and the response was not associated with MIB score, Ki67, and TP53. I think the PTKs, introducing the PTKs in the upfront setting will lead us to write the risk categorization of mantle cell lymphoma new. And this is another study of ibrutinib rituximab in the first line, also encouraging overall response rate, but the atrial fibrillation, grade 3 atrial fibrillation was high, 22%, and this is something what we don't like in ibrutinib, and we don't understand fully all the mechanism of action leading to these adverse events, but in ibrutinib, the atrial fibrillation might be related or attributed to inhibition of the PI3 kinase. Very important studies which are currently running in upfront setting is the Simpatico trial. This is in treatment naive patient and relapsed refractory patients, where ibrutinib will be combined with venetoclax versus ibrutinib and placebo. And another really not less interesting study is the Alliance trial. And this is the study, the design of the Alliance trial for untreated patients who are 60 years and old. Zanubrutinib and rituximab will be given as induction, and the patient will be thereafter randomized to continue zanubrutinib, or if they reach a complete remission, to stop zanubrutinib and take it after progression. This is also another interesting study, which is money saving and saving complication for the patients. The history and story of interesting studies not ending. Enrich trial is also currently running. Our chemo versus ibrutinib and rituximab, and we have some data with encouraging overall survival. The Mangrove trial is also another very interesting study, which is challenging the bendamustine and rituximab versus pure chemotherapy-free regimen, zanubrutinib and rituximab in patients who are 60 to 70 years old. These data from lenalidomide and rituximab, I think I have to hurry up because of the time. Another very important trial here running, pure chemotherapy-free with encouraging results. And there are many other trials running here just from the MCL network, the Carmen trial, rituximab, ibrutinib, followed by CART, upfront. really very strong one. The enrich, which will finally answer the question, rituximab and ibrutinib is better than R-CHOP and bendamustine, and so on. And the direction is in the last few years is like in CCL and CLL is to try to stop treatment once the patient reach or have MRD negative. We haven't reached yet there, but there are encouraging data. And in terms of relapsed and refractory patients, there are different options, including CART, Simpatico, with improvement of overall response rate and complete remission rate, duration of response, and progression-free survival in relapse and refractory patient. And we have many options for the second line. We have acalabrutinib, zanubrutinib. As I have focused my talk in first line, we have the non-covalent BTK inhibitor as pirtobrutinib in the third line. And as you can see here, the non-covalent BTK inhibitor, they are binding in a different region in the BTK than the first and second generation BTKs. The most acquired resistance for BTK I'm finishing. In CLL is the mutation in C481. But this is not the case in mantle cell lymphoma, so we have to be cautious. And we have novel antibodies which are being currently studied in mantle cell lymphoma. This is the scheme how we may manage mantle cell lymphoma, and because of the time, we'll go to the conclusions, which are more questions than conclusions, because this is the nature of the mantle cell lymphoma. It's really, there are many questions that are still unanswered, and some of the studies are running in order to answer this question. What is the role of BTK inhibitors in transplant-eligible patients? This is being currently addressed. The triangle, we saw it in the bridge trial and the A1804 trial. Can we improve PR in first line setting without transplant? The ECHO trial, we have seen it, incorporating also novel other agents. Can we reduce use of chemotherapy as initial therapy for patients with mantle cell lymphoma? We are awaiting the results from the Simpatico trial. In the first line, there is Simpatico in the second line, and there is Simpatico in the first line. And we have to choose between BR and rituximab plus BTK inhibitors in the first line. This is being addressed currently with the Mangrove and Enrich trial, as we could see. Should we be using BTK inhibitors in first line or save them for subsequent lines? This is still unanswered and unaddressed. Can we stop BTK inhibitor in patients reaching a complete remission? And this is currently being addressed in the Alliance trial, as we could see with the acalabrutinib. And lastly, is MRD-driven treatment is going to be standard of care, and I hope that the EA415 study will address that. With that, I would like to thank you.